Do you need anything? You're good? I'm good, actually. I was also going to mention, we have 14 programs here, and some of them are regionally focused or country focused. So if we're doing work, sort of the work that I do is cross-cutting, but if I'm doing work on Africa, or pulling my college from Africa program, we have a Canada program also. We have a Canada Institute.
Stephen Harper's picture of the front, so I was wondering why.
Yeah.
She's
Right. Yeah. So we do quite a bit, and that's a very, very good program also.
okay.
Yeah.
Very interesting.
My son is actually studying in Montreal
Miguel.
at Concordia.
Oh, Concordia.
Which he loves. He
Really?
spent last summer in Bangladesh doing work on climate displacement and sort of looking at communities dealing with post-disaster. Yeah.
Oh, really
He
nice.
loves it.
Concordia. Okay, that's
I
great.
wanted you to know that.
So good. So I just wanted to tell you that I did view your slides last night from my iPhone. I didn't bring my computer down with me. And
Yeah.
I'm
not saying
presenting.
anything but miss or anything.
No, I'm just focusing on some select
Okay.
components of the evaluation. So,
Okay, good, because
so
you saw.
you're doing the overview.
How are you
Yeah.
doing? That was very nice of you. Thank you.
Good morning.
So good, because then I will,
So you're doing the heavy lifting, actually, and thank you for that.
but I mean, because of the timing, I have too many, so I'll just. I'm gonna
Try to
just-
hit the highlights. I know I can't do mine in 10 minutes. It's like I can't.
I mean, I can do it.
14 maybe.
I'm
Oh,
just
but
going to
Joy
move
doesn't.
this
Joy
so
said
that no
she has
one
like
trips
6
on
or
that.
8
Is that
minutes.
okay?
Of course. Then we put it
Just put it across.
Sure.
Just so that. And Sandra, do you mind if I move your purse also?
Oh,
Is
no,
that
but I can
okay?
put it under here.
Okay, just so no
Yep.
one trips.
Thank you. Yep,
Yes, we're sort of moving.
absolutely.
They can hear it, ahead of time when you're coming to Baltimore.
Yeah, when it gets set up, we're in the process of doing that right now. Just got to get the grants in the door and contract
This
signed.
is
Then we can
R2HC, right? No, because is everything okay? Did you get an email from them?
Oh, no, we had problems, big problems.
But is it okay?
But they're all sorted out now.
They are.
Yeah, all except for the fact that they want us to have a banking account in British pounds, and we can't do that.
Well, that should be, should be dealt with.
But some places do, because I think Jan called finance, so you guys get a lot of R2HC.
Yeah.
And they were like, yeah, we maintain all these. It's
Yeah.
like, we can't do that. But anyway, some little challenges there, not on the proposal itself, but then our development and finance teams are a little fussy. So it's upsetting to us. You know, you get somebody who's really interested in the initiative and the work and the proposal solid, and then the back end starts. So there was a little bit of a regrouping.
At one point, it was heard that there was a potential to
Yeah.
pull it away.
Yeah, where they were going to at least delay it 6 months, but now we're back on track, and it's going to, I think we're going to be signing this month next week and trying to have this launch meeting with them in Baltimore in January. It's the second, you know, we had a Canadian grant too for 3 years where we partnered with Gordon.
Yeah.
Johns Hopkins was our research partner. So it's a continuation, same partners,
But
Of that
the
initiative.
first funding was from who?
Canada. 3 years. How old is she now?
She's 19.
19? Is she off at school?
Yeah, she's here. Well, that's one of the whole part of the things that we're all able to come. So we all moved together. So my wife got a position at Hopkins, but then she's 80% CDC with Mike's doing nutrition and emergencies. Mike Gerber. So CDC. Yeah.
Oh, I don't know.
Do you know? No, you don't know.
I don't know. Mike Gerben?
Gerber.
Gerber.
Like Michelle Hines.
Well, Michelle, yeah, we were close to her supervisor or something, or her
area.
department, or whatever.
So
That's great. We love CDC, Michelle. And
yeah, Michelle's great. Like Maya, my wife's there now. I think she met with Michelle. She's coming back tonight.
That's a little concern, I guess. There's so much we should talk about.
Yeah, I know.
Like
We're not
tons
gonna
and
get it
tons of
today.
things. No, we're not. But we maybe when mid-January when we're in Baltimore.
I'm
Daryl.
I changed that one. I don't know whether
Good morning. I hope everyone's doing well this morning. Thanks for joining us on a Friday morning. Welcome to the Wilson Center, and welcome to our discussion this morning on closing the gaps of maternal health in conflict and crises. My name is Roger Mark D'Souza. I direct our programs on global sustainability and resilience here at the Wilson Center, and it includes our maternal health initiative, which we're very fortunate to manage in collaboration with the Maternal Health Task Force at Harvard University and with UNFPA, in addition to other colleagues. And through the Maternal Health Initiative, we are working to help save and improve the lives of women and children, prevent disease in vulnerable populations, and strengthen the healthcare workforce. And most recently, we were working with some colleagues in India, in particular the Population Foundation of India, where we did some convening in India. And I wanted to share with you some of the feedback and reactions that we had from the Executive Director of the Population Foundation of India, Poonam Mutra, who was talking a little bit about what she appreciates through our dialogues and convening. And Poonam said the collective vision emergent from the dialogue is to expand existing frameworks, create new paradigms. We want to see a future that views maternal health issues from the perspective of overall health and well-being. Women's empowerment, dignity, rights, justice are values integral to this approach. So I wanted to share with you to give you a sense of how we approach this work. Many of you are familiar with us at the Wilson Center. We serve as the living memorial to President Wilson. Most recently, we were voted by the University of Pennsylvania's think tank survey as the #1 think tank globally for transdisciplinary research. And this is important for us because the work that we do on maternal health crosses a number of disciplines, and we're particularly looking at the policy relevance of that research. We know that when we hold these dialogues, they move above and beyond just the conversation here in Washington, D.C. And we're pleased to have some colleagues from Fenton who are working with J&J live tweeting for us today also. So thank you very much for helping with our live tweeting and getting the word out on social media. So once again, welcome. I know that many of you are familiar with the topic, and many of you may know that more than a third of maternal health deaths worldwide occur in fragile states. We'll be talking a little bit more about the evidence and data behind that, but this is a topic that we consider to be very important here at the Wilson Center. Most recently, just earlier this year in June, we held an all-day event called At the Eye of the Storm, Women and Climate Change. And part of that discussion specifically looked at questions about women's reproductive health rights in conflict and humanitarian settings. And this was an issue where we saw a number of the maternal health issues come up again. Most recently also, just a couple months ago, I was in Oslo. We collaborate quite closely with the Peace Research Institute of Oslo. And they convened a meeting in which I participated, looking at the gap between research, healthcare providers, patients, and policies, particularly with regard to maternal health care in conflict and humanitarian settings, particularly on the continent of Africa. So we had a number of researchers from Africa who were presenting the research results and programs that are specifically addressing maternal health priorities in conflict and humanitarian settings. And it was very interesting because we had these live perspectives from the field, but it also included a discussion about what is the policy relevance of this work. How do you engage policymakers, and how do you engage donors, and what it means for both development assistance, aid, and humanitarian assistance in these contexts. So I hope that will be part of our discussion today also, and we will also have an opportunity to talk a little bit further about about what it means in terms of corporate engagement and the ways that the corporate sector views some of these issues in these settings. So I'm thrilled that we have a number of colleagues here with us in person and also online from Syria who will help us go through the agenda today. And we're going to start with Dr. Paul Spiegel, who is going to talk a little bit about the data and evidence on maternal health in conflict and crises. So Paul is the director. He's most recently come back to the area from Geneva, and he's the director of the Johns Hopkins Center for Humanitarian Health. Is that the correct name? That's it. And is a professor in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. And he lectures and undertakes research in humanitarian emergencies. You have his background, you have his bio sketch. Most recently, he was the Deputy Director of the Division of Program Support and Management at the UNHCR in Geneva. And he is also the chair of the funding committee for the Difford and Wellcome Trust funded research for health in humanitarian crises, or R2HC, and is on the editorial board of the journal Conflict and Health. So Paul, we're thrilled to have you here. Welcome, and I hand it over to you. Thank you.
Thank you, and it's a pleasure to be here. I note actually, other than Jim, myself, and you, it's all women here. Which is interesting. But that's good. Usually it's the opposite, so that's good to see. I have 10 minutes, so I have some slides, and I want to start first with just some overall background about the current state of where we are in conflict. And it's wonderful that we have a colleague from Syria, because much of what I'll talk about, I think, relates to Syria and at least its consequences. So to begin with, you can see, I'm not going to keep on turning, that's me, there we go. Perfect. Okay, so I'll have to turn back once in a while just to see some of the slides where we're at, but you are familiar with the current situation, and there's now well over 65 million displaced persons, forcibly displaced persons. All of this data is from UNHCR, but here we're including internally displaced persons that haven't crossed a border, refugees, as well as stateless people. And you're reading probably in the paper about the Rohingya in Myanmar. Very, very sad. And but all of the Rohingya, both in Myanmar as well as in Bangladesh, are stateless, which means absolutely no papers and no rights. On top of that, there are, and this is just, we don't know how many, but the more than 65 million, 200 million people in the world are actually affected by conflict or natural disasters but are not displaced. Aleppo is a good example right now. So there's a huge amount of people that are affected by these situations that are actually not displaced. And then where the displaced go, they have an effect on host populations as well. So the number is extremely large and getting bigger, unfortunately. The next area I wanted to talk to you about is, and this relates a little bit, started in the Balkans and Kosovo, Iraq, and now Syria, is how conflict and how we respond and how it's changing. So I have on the slide here the humanitarian norm was and still is, because it's not dichotomous, but we're now looking, much of the way we respond right now was based on a model of in sub-Saharan Africa, or even before in Southeast Asia, which was really low-income countries, primarily camp settings, primarily when there were weak governments and not sufficiently capacitated local NGOs. And finally, at that point, because it's in sub-Saharan Africa, communicable diseases were the most important, and that's what we spent most of our time on. That's still the case. I mean, one of the problems that we see right now is Syria, rightly so, is getting a tremendous amount of media, but we're not hearing enough about Central African Republic, about Mali. Maybe a bit more we hear in Boko Haram, and what is in Nigeria, and what is reported in the U.S. is incredible. It's so different from what's reported in Europe. It's, I would say, much narrower, obviously far too U.S. focused. So there are a lot of other scenarios out there where we still use the old norm, but the current situation dealing with middle-income countries. We now know that more than 50% of refugees don't live in camps. They live, and many of them are in urban areas. in Syria and all the countries surrounding Jordan, Lebanon, Turkey, middle-income countries. We're looking at non-communicable diseases, cancers. We're looking at more expensive care. Frankly, when you compare Chad to Jordan, it's like night and day. And we are looking at stronger governments with stronger national NGOs, which means, and this I hope will be for the future, where we're going to be governments or become more and more capacitated, and therefore, which I won't discuss today, but the roles of international NGOs, of UN agencies, is going to change. And it will mean that they will have to give up a certain amount of money and power to allow governments and local NGOs to respond and do more of the work. So I think it's four, yes, some key questions looking at the data in what I will call here sexual and reproductive health. But so how do we interpret and apply evidence in a multitude of settings? It's really difficult because there's not a one-size-fits-all in how you respond in Dadaab refugee camp, 300,000 in Kenya that's been there since 1991, compared to Aleppo right now. It's extremely difficult. So we need to have principles, but then they really need to be applied differently according to context. The other issue is it's really difficult to get data and do what we would typically talk about, randomized control trials, even some case control in humanitarian settings, particularly acute humanitarian settings. So how can we use data from development settings where we have decent data and try to apply it there? And the answer probably is to use what we call implementational science or operational research. We don't need to know if zinc or magnesium sulfate for pregnancies, if it works. We know biomedically it works, but what we need to figure out is how best it could be used in an operational sense in these areas. Do we accept poor methodological standards for studies in humanitarian settings? Because we're not going to be able to have the same quality and the same comprehensiveness and complexity in these settings due to the context. And then finally, how precise do our estimates need to be for action compared to advocacy and compared to publishing in peer-reviewed journals? And even though I'm now moved to academia, that shouldn't be our goal as peer-reviewed journals. It really should be for action, and then advocacy can be slightly different. So some of the data I wanted to share with you, and actually you had mentioned this, and I have it in quotes and underlined. 60% of preventable maternal deaths are in fragile settings. There's a problem with that data, and I'll just that data point, and I'll talk about it just to bring home some of the problems that we have. How this was contested, and it's probably incorrect the way it is phrased. The problem is that you can't call it. One cannot say in Nigeria right now or in Congo. The whole country is not fragile. It's different parts of the country, and so how this was calculated, and we've calculated this in HIV rates and others, is that you choose certain countries that have conflict, but then the data is not sufficiently disaggregated at the district level to be able to say it's these amount of people, this number of people, and here is who's affected. So what often happens is you just say Nigeria is affected in Boko Haram areas, but then you use all of Nigeria. And so that's what's happened here, and it has been rightly contested. It also had a positive effect in terms of advocacy. So these are some of the areas that we need to work on to try to be a little bit more precise. And so one of the questions are, can we say in humanitarian emergencies, and here I would say acute humanitarian emergencies, can we always assume that the outcomes, the indicators will be higher or worse, let's say, higher maternal mortality, worse reproductive health outcomes than in developing countries, in, let's say, the equivalent countries even nearby but are not in conflict? It's a question mark. The answer is no, we can't always assume that. And maybe one other thing that I didn't say at the beginning, another big change now is the protracted nature of these situations. So Syria is over 5 years, and from UNHCR's definition, that's a protracted setting. However, it's clearly an acute situation throughout on top of a protracted setting. I will just show you here just some examples on neonatal health to show that the majority of neonatal health in low and middle income countries, not in humanitarian settings, occur within the first year within the neonatal period, so within the first 24 hours. If you look at the countries with the highest neonatal mortality rates, Somalia, Mali, DRC, Sierra Leone, you can read it, they're in red. Clearly, they are the worst neonatal outcomes, and they are affected by humanitarian situations. So it's an example where we can say that fragile states, humanitarian settings, likely have worst outcomes, but then we need to disaggregate at the lower levels. But here's some data just to show you that in protracted refugee camp settings, and that's where many of us have done our research because frankly it's easier, but when you look here in the protracted refugee camp settings, generally the mortality rates, including the maternal mortality rates, are lower, and the reproductive health outcomes are better. And that's relatively easy to understand, yet we want to get away from refugee camps, because even if the rates may be better, and that's because you have more money, you have international NGOs, the mental health and the quality of life is so horrific in these camps, and it's to have another discussion. So, but this tries to show you that it really depends on the situation and the context, and that we can't always assume that refugees or internally displaced persons are worse off. I would say generally during the acute phase that would be the case. Now, looking at some of the data, and I'm cautious of time, so I'll move on, but there have been some reviews, and this one is by Bayard Roberts and Carl Blanchet of London School, and they did this in humanitarian crises overall, and then also in reproductive health. And you can see that when we're looking at intervention trials in humanitarian crises in reproductive health, there were only, out of 7,149 citations reviewed in this 1980 to 2014, only 15 met the strict criteria, meaning higher quality. And there was only one randomized control identified. The rest were observational. What we've been running into, though, and Sandy Krause and I have been dealing with this for a long time, is that this doesn't mean there is no evidence in these situations. What it does mean is there's no specific high-quality randomized trials, but there's a tremendous amount of evidence, more qualitative, throughout. And so I think Sandy will talk a bit about this. I just wanted you to be aware of a global evaluation of the Interagency Working Group on Reproductive Health and Crises. It's very important, and what this shows, this slide, and I won't read through it, is that there has been a tremendous amount of progress, and we've been living through it, and we see the progress that has been made in humanitarian settings. But when you look, a lot of these, though, are process indicators, and which is a problem. We don't have sufficient outcome or even basically outcome indicators. And there are some key gaps, and I'll just read a couple. Commodity management and security, adolescent reproductive health. When you read through, there are a fair bit of emergency obstetrical care, newborn care. All of these areas can be improved in terms of response and definitely in research. Some of the other areas I just wanted to highlight that I haven't spoken about are adolescent health, family planning, post-abortion care, HIV and other sexually transmitted infections, but because of time. But there have been advances in this area, and there's also been some research there. And I have two last slides. One is just because in conflict and natural disasters, but conflict in particular, it's imperative to talk about sexual gender-based violence because of the importance of that issue. And you know, it's not only, as everyone knows, it's not only women. And I remember being in Congo, and it was very difficult to talk about how men were being raped as well. And it was, again, a very deliberate way of doing it. And it was very hard to discuss this and actually to get services. But still, the majority are women and children. We have difficulty, firstly, getting SGBV data in any country is difficult. In the United States is difficult. It's possibly more difficult here because for a variety of reasons, but Sandy's group and others have done a lot of research in this area. It takes time because you need to be able to have the person's confidence when you're asking these sort of questions. You can't fly in and just do it on the fly. you need people, and because it takes time, it's harder to do it in the acute emergency phase. It can possibly be done more in the protracted, but there's still always major problems to actually to get the data and to have a very good idea. Generally, it will be underestimated, as we know. But still, if we can look at trends and if the bias stays the same throughout, we can at least, there are some key indicators about, even, for example, one that we used at UNHCR was for every rape survivor, did he or she receive post-exposure prophylaxis within 72 hours, for example. So, because of time, and I want to leave time for questions. These are just some of the some broad summaries. Is that it's clear that the awareness, the funding, and and the programs or interventions have increased over the past decade. Are we able to measure specifically, and is it sometimes a little bit more observational than data-driven? Possibly. But we have seen it, and it's become, and a lot of this has been through donors actually too, putting a lot of pressure in a good way to say we need you to respond appropriately. Clearly the epidemiology needs further elaboration, and it's harder to do, but I think it can be done. And now also, which I didn't mention, but technology is really allowing us to improve the way we're collecting data, the way we're able to interact with people even in Aleppo that we haven't been able to do in the past. The interventions need to be more evidence-based, but it doesn't mean, and this is where I've changed over the years, it doesn't mean that we need to have randomized control trials necessarily in these areas. We can use a lot of what has been done previously, but then we need to just make sure that it is context-specific, and you can't just do that by saying this is how I think it should be done. We can do implementation science or operational research in a more concerted manner. But again, that requires donors to give the money, because in these situations, research, monitoring, and evaluation there's never enough money, because most people, unlike in other programs for development, say this money must go to save immediate lives. But with more money in this area, we probably could save more lives eventually. And that's my last point about monitoring and evaluation. There are ways that we can do this better as well and go beyond the qualitative and process indicators more into the ultimate outcome and indicators. And again, I think there are more and more techniques now that we can do this. But one of the problems, and I guess this will be my last point, is that in order for us to do this, during the assessment phase, we need proper assessments to get baseline data. So many of us have gone into the field to do some monitors, to do an evaluation, but it ends up just being qualitative because we can gather the data at that time, but we actually have nothing to compare it to because it was never done properly at the assessment phase. Okay, I think I will stop there.
Thank you very much, Paul. So before we get on to Massimo, I'm really glad that you teed up some of the challenges in a very compelling way. You talk about principles, but really looking at what's context specific, how we can deal with implementation of science and operations research, the challenges from a methodological perspective, and the inability to at times have precise information. But you also make the case that there's a real sense of urgency. There's a question of saving lives. Yet at the same time, there's the protracted nature of what's going on, which paradoxically provides better information and data. And if you say that we need time to develop confidence, to have better data sources. So for those of us who are trying to have a sense of we need to have the evidence to take action now, we can't always wait for the peer-reviewed journals. What are your recommendations for where we can get information that's reliable now that we can use to make decisions, recognizing that ultimately it's always going to be imperfect information, right? But we need to make decisions, we need to act. What are your thoughts?
Yeah. I think part of it is, and there has been, so a couple different things. Now, in all of the situations, whether it be refugees or internally displaced persons, we have live web portals, whether it's OCHA, which is the Office of Coordination Humanitarian Affairs, or UNHCR for the refugee settings. There are web portals. I mean, if you do UNHCR Syria portal, you'll find some really good good assessments and basic things such as the 3 Ws, who's doing what where. So there's a lot of information now that wasn't available in the past. There have been ways to try to improve assessments to make them a little bit more standardized. But one of the problems is that there's a whole new area now called, it's not so new, but called information management and getting IM officers, so information management officers. It's not public relations, it's not media, it's not press, it's actually people that understand data, but can also go around to the organizations to say this is what we need. So there are some simple ways, I think, in terms of standardization. There's some simple ways, although it's just to get everyone to agree, so coordination comes down to it. But if we were all using similar case definitions, similar ways of collecting data, even if it's not the same instruments, but they can work together, we could do a lot more with what we have.
Great. Thank you very much, Paul. So I'd like to go on now to our colleague in Damascus, Syria, who's joining us online just through audio. Massimo Diano is a representative from the United Nations Population Fund, UNFPA, and since August of 2015, he's been reporting to the regional director in the Arab States Regional Office and has been providing leadership and guidance in projecting priorities and mandates to UNFPA at the national level. So, Massimo, we are thrilled that you're able to join us from Syria, and I will hand it over to you now.
Hello, yes, good morning. I hope that the voice comes through clear. This is Massimo Diana from UNFPA Damascus here. I just wanted to get confirmation that the sound is of acceptable quality.
Loud and clear.
Excellent, thank you very much. Thank you very much for the opportunity, and it's very good that I'm actually speaking after Paul, because there are a few points that he raised that are really coming very close to our situation. I would like to start on the point that Paul referred to on the issue of data, because I would like to walk you through some of the contextual information before coming into what could be possible actions to closing the gap on maternal health in conflict and crisis. While indeed we are in the context of a protracted crisis in Syria reaching close to 6 years, our challenges in terms of data collection, data analysis, and both qualitative and quantitative to be able to inform the response planning, it's still scattered at best, and we have a bit of a complication regarding to areas depending on access of UN or humanitarian partners and government personnel versus areas that are outside of our reach. And therefore, having a common methodological approach, which one focuses on quantitative information from inside Damascus, the other one focusing more on qualitative information or key informant information coming from areas under the opposition control, does create disparity in terms of the ability to generate overarching, reliable information. But broadly speaking, over the 6 years of the crisis, as health is concerned, we are saying that approximately 30% of the health facilities have been damaged, and only less than 50%, close to 45% of the primary healthcare facilities or 44% of hospitals are reported to be fully functional. So we have a situation where close to 60% of the primary healthcare and hospital providing service provision is being either destroyed, not functional, lack of equipment, lack of personnel. In terms of life expectancy overall, there's been a drop by approximately 20 years during the period of crisis. Child mortality has increased by 1/3, as well as maternal mortality has increased by close to 1/3, out of 49 out of 100,000 live births in 2011 to about 63 per 100,000 live births in 2013. Equally, all the underlying reproductive health indicators, be them contraceptive prevalence rate, skilled attendance at birth, or access to comprehensive emergency obstetric care, have deteriorated dramatically. Also, regarding the population shift do affect people. In our case, of course, of women of reproductive age and women, pregnant women, but it does also affect professionals. So we also have been experiencing a migration, displacement, as well as loss of life of many health practitioners, which also leads to a limited presence, of skilled birth attendants, midwives to be able to support, particularly in areas that are hard to reach or in the continent of Syria besieged. In terms of data, we also have limited access, particularly in the most acute humanitarian setting inside the country, on the actual availability and the quality of the emergency obstetric care that might be available. A number of partners are trying to provide support, but access limitation as well as staffing limitation and capacities are hindering the ability to ensure sufficient quality of care. I would like also to indicate that in a context that as one in Syria, we're also seeing broadly in the world, adolescent girls and women are always more exposed to exploitation, abuse, sexual slavery, and general sexual violence as one of the main areas of protection needs for women and girls. But in the context of Syria, where a new increased phenomenon of child and forced marriage, also due to the presence of foreign fighters in many instances, has reduced dramatically the age of the first marriage for young girls, therefore also the age of first birth of young girls. This also couples with the areas, in most cases, with these young girls are in the most poverty-stricken area, where they have less control on whether to become or control their pregnancy. Comparing to other age groups, adolescents who are married have both the lowest use of contraception and the highest levels of unmet needs. It is also clear with the limited health provision, the access and limitation, as well as the dangers posed by the active conflict. When young girls become pregnant, they become also higher risk of maternal deaths and pregnancy complications. When a girl becomes pregnant, of course, her life does change radically, and in the context of a limited movement provided by the lack of access, her challenges also increase. We do not have sufficient methodologically acceptable data on the prevalence of child and forced marriages and therefore related pregnancies. But when we have had opportunities to meet young girls that are coming out of the besieged areas, we have noticed that the age of the first marriage has dropped from 15, 16 pre-crisis to 12 in some cases, even to the age of 9. In terms of the way forward and how to support the closing of the gap in maternal health, what we need to also ensure that we have a proper plans for the integration of the maternal and the neonatal health, ensure that we have strengthened the investment in the care before, during, and after the pregnancy, which means putting the issues of the pregnant mother at the core of the humanitarian response, where too often it is not the case. We need to review the humanitarian policies and the response plans to ensure that the needs of an estimated 360,000 women who may be pregnant at any point in time in the current crisis are actually met. We also need to ensure that in areas where there is no presence of the government, therefore the institutions, for example, in regarding to birth registration, that also those policies are updated and the mechanisms are identified for the registration of those births that take place in areas not administered by the government, and therefore the acceptance of whatever birth registration may have been possible to be recorded. There's issues of ensuring the participation of communities, particularly in areas of higher poverty. The pregnancy is left responsibility, the burden of the young girl, and to her closest siblings. Luckily, the mother, but there is a less collaboration and participation of the community, and we therefore need to ensure that we are involving the communities in understanding the participation and the support that the social networks can provide, particularly in cases of adolescent pregnancies. With over 60% of the health facilities having been affected by the crisis, what we're also witnessing that a majority of the services are provided by the private sector, and therefore the need to partner and establish a shared understanding of policies, procedures, recording, and management of prenatal, postnatal care is also strengthened between the public, private sector, and the humanitarian partners. Capacity development becomes also, in a pediatric crisis, a critical area of priority. There's a need to support midwives' training and ability to provide skilled attendants, birth attendants, to support care both prior and after the birth. There is also a need of focusing and ensuring a better understanding of those categories of the population that live in more remote areas, where they'll be either in camp, but also in camp settings, but also people who are living in host communities, and the issues of access to equitable care is also another high priority. In order to also ensure the stronger support to healthcare, is also a question in the context of, particularly in the context here, is a question of availability of essential commodities. With a highly depleted local market, both in terms of processing or production, and a very long lead time, and the effect of the unilateral economic sanctions against Syria, the lead time on international procurement also provides a major hindrance to the ability for the humanitarian sector to provide the sufficient supplies to the reproductive health clinics. They provided a general overview. I'm not going to be discussing the details of what UNFPA does. I'm happy to take questions if you have any. Over to you.
Great. Thank you very much, Sima. That was a very comprehensive, and I think we very much appreciated the different initiatives you have outlined to close the gap. So I'd like you to imagine for a moment, you are sitting in Damascus, we are here in Washington, D.C., and, we are convening a dialogue, conversation on this issue, and I wonder if you could reflect and perhaps share with us some of your perspectives on when we have these kinds of conversations in a place like Washington, D.C., among a community of people who are interested in and supporting these issues. What do we get wrong? What do you need us to guard against? You're there. You're on the ground. You're on the front lines. We're here in Washington, D.C. having this conversation. What do you want us to be mindful of? What do we need to pay attention to? How can we be more helpful to you? Does that question make sense?
It makes extreme sense. Thank you very much. Trying to stick on the topic of today's conversation, and again, I'd like to link back to the speaker that preceded me on the issues of the use of models from developmental settings for humanitarian setting, their usefulness and their relevance, as well as the issues of methodological approaches. What I think the scientific and the expert community who is outside could help the humanitarians dealing with this very sensitive area of work to find an agile mechanisms for how data could be processed, fast assessment methodologies that may not necessarily be the strongest from a scientific point of view, but are feasible and practical and adaptable and implementable on the ground. Also, issues of technology. How could, for example, maybe development of, we have a lot of contacts around different communities. We all have access limitations, but the mobile networks, broadly speaking, are functioning. could the scientific community with humanitarian experts sitting outside the country come up and develop simplified tools that can be deployed via a smartphone, or that could be quick data collection methodologies that can then have a faster triangulation be deployed through WhatsApp mechanisms, Viber, whatever other technological tools that might be available. And this will definitely help us getting a better understanding of what is the reality on the ground, and be able to go to the granularity of what is different from one location to the other. It was interesting when Paul was saying about the questions of Nigeria versus the area affected by Boko Haram. The extrapolation of data from one area is used for defining the context of a country. In our case, not exactly the same, but a similar phenomenon takes place. Different areas, different besieged areas, different hard-to-reach areas are all being lumped together with almost having the same type of problem. Whereas in reality, the granularity of the challenges and the priorities are different from one location to the other. And the challenge for the humanitarian community here is to be able to have a better nuanced understanding on that issue. On another area where I believe that maybe experts like yourselves in those settings outside of a crisis country, whether that be Syria or Yemen, it would be the same. It would also be useful for us to understand the dynamic, how to be able to respond in an area where we have limited capacity in, for example, a Arab context and use of contraception or family planning tools regarding adolescent girls. We don't have, as I said, the sufficient quantitative data. We have sufficient qualitative and anecdotal information, but it would be interesting, a dialogue between the scientific and expert community and the practitioners on the ground, so that this analytical thinking can actually be carried out by outside experts that may have the time and expertise to work on it, while we on the ground can actually focus on trying to deliver the response, which Aleppo was mentioned a few times. It is the area that's hitting the news, of course. But let me remind all of us that we have several tens of thousands, hundreds of thousands of people, who many are women and young girls in many areas of the country that are being affected the same as those in Aleppo. So we are responding left, right, and center, and it would be important to hear from a scientific community support on doing the analytical part, so that it will help us to focus on the operational response. I hope I addressed, at least in part, your question.
Great. Thank you very much, Mr. Simon. I think you've taken up a number of themes that we also heard from Paul, so that's excellent. Thank you very much. I'd like to move on now to Sandra. Sandra Krause is with the Women's Refugee Commission, where she provides strategic direction on sexual and reproductive health advocacy and research. She's been active in the public health arena for about 25 years, 20 of which have been devoted to international health, working in various regions throughout the world. She has conducted reproductive health needs assessments in multiple emergency settings and has established programs for refugees and internally displaced persons in Somalia, Sudan, and Malawi, where she was a country director. So, Sandra, I'll hand it over to you now. Thank you.
Thank you. Thanks so much. I really appreciate the opportunity to be here. So thank you to the Maternal Health Initiative. Thank you all for making the time to be here this morning. I think what I'm going to do is provide a little bit of context to reproductive health in humanitarian settings. So just very briefly touch on a little bit of history. And then I'm going to pull some of the findings that came out of the IWAG, Interagency Working Group on Reproductive Health and Crisis. We call it IWAG, but it should probably be pronounced IAG or something, but IWAG's easier. I'm going to pull some of those findings that were particularly apparent in the funding studies and in the in-depth field assessment of the global evaluation. So therefore talk about some progress that's been made and some gaps that remain, particularly in the issue of maternal newborn health. Okay, so with that, oh yeah, I have to do this. Coordinated here. Okay, so the IWAG, so first of all, the refugee and internally displaced persons, including adolescents' rights to reproductive health, were first recognized in 1994 in the International Conference on Population and Development. This was really critical because in 1995, UNHCR, UNFPA, WHO all went, we really have to do something about providing reproductive health amid all the other demands in the onset of these humanitarian emergencies, and they did. The U.S. State Department funded a full-time position actually at UNHCR to initiate the IWOG, which involves some 40 different agencies, and one of the first tasks of that IWOG was to establish guidelines for the field. And I think they were among the first guidelines of any type in the humanitarian field, so yay. Few good men, but mostly women, who led that effort at UNHCR and UNFPA. And in those guidelines, they established a set of priority interventions to be put in place at the same time humanitarian actors are trying to meet basic and survival needs and prevent infectious diseases. There were to be these coordinated activities to prevent excess maternal and newborn mortality, to prevent the transmission of HIV, and to address sexual violence, so to work to prevent it and also to provide care to survivors of sexual violence. It became known as a minimum initial service package. UNFPA established a number of kits of supplies that support those priority interventions. So I just wanted to explain that historically, the IWOG has put forth these guidelines. So the first ones I used myself in the field when they were being piloted in 1996, but they were official in 1999. They were updated again in 2010. Paul's slide showed a synopsis of them. And just to say they're currently under revision right now with a new version coming out in the spring of, early spring of 2017. So the IWOG, develops these guidelines, develops tools and resources to support the implementation of reproductive health in humanitarian settings, and undertakes these periodic evaluations as well. So I'd like to highlight kind of the state of the field just a little bit. So the IWOG today is housed at the Women's Refugee Commission as a dedicated coordinator and an 18-member steering committee with all the relevant UN agencies and international NGOs, humanitarian and development organizations, working together to push this issue forward. So it's really critical, we felt, and the reasons why the Women's Refugee Commission has tried to support it is to have coordinated and collaborative efforts, and that's been really helpful in moving the agenda forward and making the progress that we have over the last 2 decades. So in terms of the IWOG's global evaluation from 2012 to 2014, it builds on the one that was taken a decade earlier, 2002 to 2004, in that it involves a synopsis. It's actually a snapshot of what reproductive health looks like in a given point in time. So it's like a kaleidoscope of multiple different studies that we brought together, both in the 2002 to 2004 and in this study, to try to get a picture of the field at a certain point in time. So it involved a literature review, an assessment of agency commitment capacity to provide reproductive health in humanitarian settings, which in this case involved 82 different agencies from both development and humanitarian fields. It also included in-depth assessments in the field on the availability, use, and quality of reproductive health services in 3 countries, South Sudan, Democratic Republic of Congo, and Burkina Faso. It also did an assessment of this MISP. Is this MISP being applied at the onset of a humanitarian emergency within the Syrian refugee crisis in Jordan? So the assessment involved a camp setting in an urban context in Jordan. And then it involves an analysis of crisis funding trends for reproductive health. And there were 2 studies in that, and I am going to pull those out and discuss them a bit. One of the studies looks at the OCHA's financial tracking system, and the other study looks at official development assistance. So I want to talk about those and how they relate to the different components of reproductive health in particular. And then Paul has already mentioned that UNHCR's health information system was part of this evaluation as well. For years, UNHCR's had this health information system and has collected critical data on reproductive health, which is great and really informed this study. So the capacity to address reproductive health in crisis has increased since the last global evaluation of 2004. development agencies have jumped in to participate in humanitarian relief, and that's helped quite a bit. But almost all the respondents reported increased human resource capacity to program reproductive health in humanitarian settings in all the technical areas of reproductive health, except for perhaps cervical cancer screening and treatment and safe abortion care. So just very briefly over these slides on the capacity study. More than 2/3 of agencies reported having an internal policy or mandate to program reproductive health and humanitarian emergencies. So 68% of the 82 agencies reported that they have that mandate and policy. 49% of the agencies reported that they have had increased funding from 2004 to 2012 to address reproductive health in humanitarian settings. So quite a bit of reporting of increased capacity to address services. The MISP study showed there's increased commitment to the MISP in humanitarian emergencies. What does that mean? Well, there's a lead agency generally for reproductive health in these crises within the health cluster to lead coordination, to fundraise, to get the supplies in place, and for everybody to work towards getting that MISP in place so that the humanitarian actors can move on to providing comprehensive reproductive health as soon as possible. So a lot of major improvements. Now onto the funding studies. I want to talk a little bit about the Overseas Development Assistance study that was done in 18 conflict-affected settings. Funding for reproductive health increased 298% over the 2002 to 2011 period. So that's quite a bit, especially if you look at overall ODA, Official Development Assistance, increasing 178%. But a large part of that funding actually went to HIV programming. Probably 56% of it went to HIV programming. Not that that's bad, but I just want to point out as we go along here where some of the gaps are. In addition, the study looked at comparing conflict-affected least developed countries to non-conflict-affected least developed countries. And interestingly, it showed that conflict-affected least developed countries received 57% less ODA assistance than non-conflict affected countries, even though most reproductive health indicators in those conflict affected countries are worse. So, I mean, some of the reasons for that might be, just security issues, governance, capacity to absorb that kind of money in country, or it might be attention to policy or media coverage as well. So, worth noting the overall funding picture. This just shows the per capita ODA difference for conflict affected versus non-conflict affected. And then the other funding study I want to talk about is the OCHA financial tracking system. This study involved the review of 11,300 some different health and protection proposals and what was funded in them over a 12-year period. You'll see more data in this next study was available in the latter part of this. More data was available from the financial tracking system in the latter years of the study, so we could glean more information. But if you look at the components of reproductive health funded, good news, you see a lot in maternal newborn health there. It had the most funding of all. But a closer look at those proposals shows that the funding went largely to what we kind of call lower hanging fruit, easier to implement services like antenatal care and postnatal care and nutrition programs to support them versus a life-saving emergency obstetric and newborn care that's so critical and probably more costly as well. We see progress there in GBV funding over those years, rightfully, because that 10 years ago was one of the biggest gaps in reproductive health programming was GBV, and also I think substantive attention to HIV, which I give all credit to Paul Spiegel for moving forward in the humanitarian field. So those two areas were the weakest in the 2002 to 2004 area. They've grown quite a bit in terms of attention and effective programming in the field. But take a look at family planning. it's so little, and we know how family planning contributes to positive health outcomes, prevents maternal mortality and HIV. So this is one of the themes that kind of came across, very low attention to family planning, and safe abortion wasn't anywhere in those 11,300 proposals over 11 years. There was some attention. There were 13 proposals, I understand, that contained post-abortion care, so if someone had a miscarriage or an unsafe abortion, they would be able to access post-abortion care. So those two areas, major gaps in terms of what agencies are proposing to do and what they're actually funded to do. And then you take the funding studies and you look at the in-depth assessments in the 3 countries of DRC, South Sudan, and Burkina Faso. And out of 63 health facilities, only 1 hospital and 1 health facility were adequately staffed and equipped to provide comprehensive emergency obstetric care. These more challenging clinical areas are the most in need in the field in terms of attention and support. Then clinical care for survivors of sexual assault was also a gap in actually the MISP assessment, but in the 3 in-depth studies. And it's consistently a gap, I'd say, in almost every humanitarian emergency I go to. I think one of the reasons is that the ministries of health do not have an existing protocol for care for survivors of sexual violence. It's not a difficult intervention, but you have to have the protocol, and then you need nurses, doctors, midwives, and people trained in it. So whenever NGOs go to the field and they aim to set up these programs, they have a whole group of staff who don't know how to provide these services. So and they don't necessarily have a national protocol either. So it's a huge gap in the field. And then where it is set up, where these MISP services are set up, there's not enough effort to inform the communities about the benefits of seeking care. Because if a woman's been raped, she's obviously going to be in shock anyway. She's going to need a family member, a friend, a neighbor, someone to say, you know, you need to get health care to try to prevent pregnancy and the transmission of HIV. And that has to be weighed against the fear of, you know, the stigma associated with reporting or the fear of retribution from the perpetrator. But the people don't really have the opportunity to weigh those 2 things and make a decision about their best interest because they're not aware of the benefits of seeking care or where the services actually are. So a lot of community information, education and communication needs to be done to improve that. So just to say again, big gaps in the in-depth studies in the field in terms of family planning, emergency obstetric care, emergency contraception is a gap, but also long-acting and permanent methods of family planning. And so despite all the established guidelines and all the efforts we're making to get comprehensive reproductive health in the field, it's still a really critical gap in protracted crisis as well. And then finally, I have put out on the table the compendium of these 7 studies. And if you weren't able to grab a hard copy, they are online at the IWOG website, the whole compendium is, and also some summary with more recommendations than I could go into here. But clearly humanitarian contexts are often characterized by short-term funding. There aren't long-term funding initiatives to make sure programs are fluid and cohesive and innovative. More needs to be done, I think, at the national level in terms of disaster risk reduction and preparedness for these emergencies. And then in terms of the communities we reach out to, we need to expand a little bit more now and start thinking of people who are living with disabilities, LGBTI populations, and adolescents most certainly, and very young adolescents, more attention to populations who have historically been marginalized. So that's it.
Thank you very much, Sandra. There's a lot in there. So for those of us who will look at the outcomes of the evaluations, I wonder if you could talk a little bit about what's new in terms of what was found. What did we not know before, and what is most actionable in the short term for us? And I'd like you to imagine, so we're here on the 6th floor in the Wilson Center, and you step into the elevator. And in that elevator is your target policymaker. This is the person that you have been wanting to reach, who is able to make action, to take action. You have that ride from the 6th floor to the 1st floor to engage him or her. What can you say quickly was really new, surprising, and actionable that will convince that person to want to find out more and to move to action?
I guess the most surprising thing was probably for me was the family planning issue, that it was as much a gap as it was, because I thought more progress had been made in making these services available. And there has been some in terms of making pills and injectables available. But in the Nepal MISP assessment, there was a huge demand for IUDs. That's what the women were used to. That's what providers were used to doing, and there weren't supplies to do it. So I would say family planning and building on what we've heard from other presenters, Paul and Massimo, logistics, supporting logistics, because commodity supply and stock out are a big problem. And there doesn't seem to be, apart from UNFPA's work, a lot of expertise or capacity in logistics for reproductive health supplies. It's because UNFPA does a great job with the kits, but they're only designed for the first few months of an emergency, and NGOs and everyone needs a lot of help to transition to more comprehensive supply chain, to transition to other ways of financing, as Paul was alluding to, reproductive health programs. So I would say family planning, safe abortion care, in places where women are raped, and this has come up again and again, the gender-based violence, people come to us and go, what do we do? And what's important, I think, is that in many of these countries, rape is legal in cases of rape and in certain contexts, and there are providers that are already on the ground. So I think, like what Paul said, we have to learn to operate differently. If I could do anything, I would design a system that could quickly, and maybe Paul can tell us about that because he was at UNHCR, but could quickly map all of the existing capacity on the ground at the time of emergency, because there are local groups working in SGBV and family planning and safe abortion care and doing their services. They're often roughshod over by the humanitarian system, and even if an NGO can't do safe abortion care, they can know where a woman can get safe abortion care or access to long-acting methods of family planning. But the mapping piece of it, I think those who are working in urban contexts are doing more in this area, but it seems in this day and age that should be a fairly ready thing to do. Of course, it would have to be combined with vetting. You can't just say the service is there. You have to know the quality and the characteristics of the, providers and all of that. But there has to be some vetting for it. But I would say family planning, good logistics, and better vetting of existing services.
Thank you. Thanks. I'd like to move on now to Joy Marini, who is the Executive Director of Worldwide Corporate Contributions at Johnson & Johnson. And she comes to that position having spent 6 years working with J&J's Pediatric Institute. She leads global philanthropy for J&J focused on improving the health for women, children, and adolescents. And this includes programs internationally focusing on maternal and infant survival, child health, and women's and girls' empowerment. She leads a 5-year commitment to the Every Newborn Action Plan, which is working towards improving skills and knowledge of birth attendants and mothers in 20 countries. So Joy, I hand it over to you.
Good morning, everyone. I am really thrilled to be on a panel with such knowledgeable people in terms of working in conflict and crisis. I would say I am less of an expert in conflict and crisis and more of an expert in being told no. And that is what I'm going to talk about today, what happens when you're told no. So the first thing I would like to do just quickly, because it might kind of change so if you want my talk to be short, how you answer this is going to, really affect the length of the presentation. I'd like to know who's here. I mean, if you are with the private sector, are there any people from the private sector, civil society, NGOs, UN agencies, students? Any students? We have some students. Did I miss what else is out there? Government? Oh, we're in DC. I forget. Government. Okay, great. Just because I wanted to have a little level setting in terms of where exactly we're going with that conversation. So I wanted to back up a little bit and talk about the SDGs. And one of the things that's happened with the Sustainable Development Goals is many private sector and countries and multinationals have made commitments to the Sustainable Development Goals, and Johnson & Johnson is among those. And one of the things that happened as a result of that is because the Sustainable Development Goals are for everyone. They are, whether you are a developed nation or a developing nation, everyone has goals. And so that has really forced our team to think more about these two ends. So we were working a lot in the middle. So countries that had stable governments, countries that were middle-income countries. We weren't doing very much in the developed world at all in terms of development, and we weren't doing as much as we should in fragile and conflict-affected states. So the Sustainable Development Goal commitment that we made, and there are 17 goals. We did not make a commitment to all 17 goals, and ours are really focused on health, as you see, global disease challenges, essential surgery, women and children's health, health workforce, environmental health, and overlaying that gender equity. And so that really has made us think about these other two ends and what our intention is in those two places. So when we think about fragile and conflict-affected states, we're talking about, and we've had, I'm backing up a little bit. I think we were ahead of that. So I'm backing up a little bit about what we're actually talking about here, or what I'm referring to anyway. What is a fragile or conflict-affected state? And, we're really talking about communities not receiving essential services for a lot of reasons. They can be economic, and that is everything from, human capital, including adolescent and youth unemployment, the economic foundations, environmental. We are talking about political inclusiveness, corruption, oppression, security, vulnerability to violence, societal and inequality, and there are many definitions, and that was one of the things that as the private sector we were trying to figure out what exactly are we talking about and which countries are those. And that was a bit of a moving target, and now after Paul's talk, I'm suspect of every piece of data we've looked at, and I'm not trusting any of them. So maybe we can just throw all the data out. But regardless of whether the data is perfectly accurate or needs other explanation, one of the things that we do know is that a large percentage of the global poor by 2030 will be in fragile contexts. So we saw a lot of this data earlier. Paul presented some of that. And we had and Massimo gave us really a nice picture, and I think when we think about what does this look like for women and children, I think about a woman who is displaced and was traveling through Budapest and had to have her baby under a train trestle without any help, without any skilled birth attendant, and without that beautiful, clean maternity ward. And she said, that was the most beautiful moment of my life, but it happened in a horrible place. And so in reality, that's what that looks like. And she was lucky that she and her baby actually survived. So the private sector does have a role You know, the private sector has been engaged. You look at the green one, if you go backwards, this is maternal health and newborn and child health, and you can see the green. The private sector does have a role and has increased their role over the years, and they bring other things to the table. You know, expertise, advocacy. We have creativity, a propensity for risk taking. So there is a role, but there are constraints. And when we think about constraints, and it's interesting, I just spoke about this with the conference board last week, and it was so interesting to see how these private sector players, I mean, the very first thing was, we don't have a business interest. And I could see a few people in the rooms, their eyes just kind of glazed over when I started talking about it, because the minute they heard this and they thought about their business interest, they said, well, that's not for us. We can't support work there. So that was very interesting. Perception of risk, high risk of failure. Are we going to invest there and really have no social impact or return? Scale. The private sector loves these two words, scale and sustainability. So if any of you are with NGOs or with government and you speak to private sector about things that you would like for them to support, the first thing they like to say is, well, can we scale it, and is it sustainable? And I have a very hard definition of scale, so my expectations of scale might be a little low, but because what I define scale as is very high. But you know, there's this impression that with rapidly changing conditions that we're not going to be able to scale. That's not going to happen, and that all the weak institutions, including, as Massimo and Paul also mentioned about working with local institutions, that we're never going to reach sustainability. So I was having dinner, I guess 3 or 4 weeks ago, with someone from Liberia, and we were talking about this, and he said to me, I know that's the terminology that's used, fragile states, and he said, but that's not the way I see myself, and that's not the way I see my country. And I just went, terrible faux pas on my part, and I said, well, do you have a suggestion? What should we? What do you have? Maybe we could start changing the vernacular. What other words could we use here? And he really didn't have any, but I was thinking about it, and I've decided that FCAS is fulfilled communities achieve success. So that's my new FCAS, fulfilled communities achieve success, because if I believe in human beings, and I believe that if they have support and infrastructure, that they will create the communities that they need to be prosperous and to live optimally. So anyway, so I get a lot of no's. Let's support this, or let's work in this area, and I get a lot of get a lot of no's. Now, even with my glasses, I have to go to the big one, and I don't know if you can read these. But so my suggestions are to consider, for the private sector, or for those who are looking to work with the private sector, consider an alternate rationale for engagement. And one of those is, for me anyway, you've made an SDG commitment. What does that really mean? Are you only going to pick the low-hanging fruit? Another one would be, while it may be further downstream for businesses, these are markets. They might not be markets today, but if you think about human potential, these are markets. Talking about balancing a portfolio to accommodate the working in these areas. So perhaps an entire portfolio, given that there's risk and there's business interest and all those challenges and constraints we have at the top, perhaps balancing a portfolio so that a percentage can go into this, into this kind of work. Aligning with local priorities. If you are able to work in these places, start aligning with local priorities, working with local organizations, and that really is a part of tailoring models that respond to high volatility and partnering to reduce risk as well. All of those things go together. This is about locally driven solutions and about, and I can give you an example of that. Actually, I'm going to wait for a slide, but I will give you an example of that. Locally driven solutions that can be sustainable because what you are doing is not required to be there forever. So if after you leave, there will be somebody there to continue. And increase your timelines. And this speaks a lot to some of the data that you were talking about. Our timelines in the private sector tend to be way too short. And there's not enough time to collect the baseline data that we need at the beginning, nor to do the data to even show whether we were successful to the end. And in a fragile state, you might need even longer timelines. And so I think it is possible to work in these areas, and it's possible to be successful and really provide value in these areas, but we have to use a different lens when we think about investing here. And that is a big shift, at least for most private sector it is. These are just a few examples, and I realized I should have probably put this year. This is actually just 2016. We joined UNFPA in the Safe Birth Even Here campaign. As a part of that, we felt that joining a campaign wasn't really putting our money where our mouth was. It was just putting our mouth there. Not our money. And so we are actually working with them in Haiti and Liberia on emergency obstetric services. But typical of what I just talked about constraints, we were getting ready to launch, and then Hurricane Matthew in Haiti. And suddenly everything went a little backwards, and timelines went a little backwards, but that's okay. We understand risk. The amazing thing that grew out of that is another private sector company came forward, and we're going to be partnering with them for some very short-term solutions while we continue to think about how we're going to build healthcare capacity as a longer-term solution with a country. So, you know, it's a little bit of, and I have to say, a Band-Aid effect because I'm for Johnson & Johnson and we make those. So we're doing a little bit of a Band-Aid in the interim, but still continuing to keep our eye on system strengthening and working directly to improve emergency obstetric care and newborn care. The Syrian refugee crisis. This was the example I said that I would mention about local solutions. We have been working with Save the Children on the refugee crisis for child health and resilience and early child development. And I was mentioning to the panel here that when I was at the International Pediatric Association conference, every opportunity, Turkey, Jordan, Lebanon, the pediatricians would, it didn't matter what the topic of the panel was, if they could raise their hand and say something, they talked about how they are suffering, how they don't have the capacity to care for the children that have come in from Syria, that they're trying to care for their own populations. There weren't enough pediatricians to begin with. So we decided to really work directly with these pediatric societies because long after we're gone, they're still going to be there and they're still going to be caring for children. And every country will be a little different depending on what that pediatric society feels is the most important need. So some of them are actually looking at adolescents rather than young children, and others are looking at newborns. So, of course, humanitarian relief is a long time kind of platform for Johnson & Johnson, and then this year also there was a Zika response in Brazil. I would want to mention that we are still working on Ebola. And an example of private sector really coming together in terms of our citizenship and sustainability, or CSR, that is part of my team and the businesses is when Ebola hit it was really fascinating to watch the response of the businesses because it was all hands on deck, basically, to create a vaccine. They dropped literally everything they were working on to focus on Ebola, everything, and to focus on creation of a vaccine. And at the same time, because we made a longer-term commitment, we are still working to figure out exactly what we can do to strengthen the health system so that, when these kind of things happen, they are not in such a fragile condition to begin with. So that's sort of my practical solutions for trying to get the private sector to invest and how they look at it. And so I welcome questions.
Thank you very much, Joy. I think one of the things that you mentioned to us in terms of advice, in terms of thinking of how we engage the private sector, is to be able to talk about scale and sustainability. And I wonder whether you could share with us a success story within Johnson & Johnson that internally your bosses are excited about. I'm not talking about the PR and we're doing good corporate work, but internally, is there an example where these questions of scale and sustainability has really resonated among the folks that you have to report to that we can learn from?
I think that it's interesting that some of the places where we've had success with scale started out on the list of fragile and conflict-affected states and perhaps are not on the list now, or when you look at the top 10, they're now dropped to 12 or so. I will say that for any program that we've had real success at scale in any context, the reason is because the program was built from the beginning with local ownership, and it was local organizations and government that actually produce scale. So others from the private sector may disagree, but I think that it is private sector's job to encourage scale and create and help to have the data that can allow countries to scale. I'm not sure it's the private sector's responsibility to scale. That, I don't know if anybody else agrees with that, so I'm not speaking on behalf of anybody but myself there, but I do think that the places where we have scaled, we have also had incredible data. So, and the data was often collected and analyzed in coordination with the country governments.
Great. Thank you very much. Let's open it up to you now. Massimo, you're still there with us?
I think the line dropped.
Okay, so we'll see. Will we try to get him back, Francesca?
I asked him if he'd like to, but...
Okay, so let me know. So as we come to you, my colleagues will come to you. Please give your name and affiliation and get quickly to your question or comment. So yes, please.
Hi, thank you all for being here today. My name is Dr. Taylor Winkleman. I'm a science fellow in Senator Markey's office. And I recently went to an illicit financing talk where they said Switzerland's new rules for freezing terrorist finances is the 80-20 rule. And so if you're 80% sure that this guy is doing the wrong thing, then you freeze his finances, and then you look for the remaining 20%, because that last 20% of certainty takes so much time and so much energy that you lose so much in the interim time. So my question for all of you is, if we apply the 80-20 rule to humanitarian crises, where we use some common sense and we feel roughly 80% certain that something's going to work, is that good enough for us to take action? And Ms. Marini, is that good enough for the private sector to invest in?
I think my mother-in-law is on this panel.
Let's take another question here.
Yes, so my name is Omrana Pasha, and I'm in the Department of Population, Family, and Reproductive Health at Johns Hopkins Bloomberg School of Public Health. And my question to the group is regarding both donor and organizational fatigue in crisis situations. We have been in crisis in Afghanistan for 30 plus years now. We have a third generation being born into war in Afghanistan. I work in the Badakhshan province of Afghanistan, which many years ago, the School of Public Health showed that the highest rate of maternal mortality in the world was in Badakhshan province. It has gone down substantially since then. And we now have data from areas in Badakhshan showing really remarkable reductions in maternal and neonatal mortality rates, which are well beyond the goal for Afghanistan for the MDGs. And it's very interesting because the Taliban and the government forces are fighting, and data collection and maternal newborn health care provision is going on side by side. So today I had a conference call with my team in Badakhshan this morning, and they said, well, things will get better because seasonal insecurity will go down now because the fighters have all gone home for the winter. But they will be back, and so, you know, there are a few people still invested in working in these places, but by and large, I think the world is tired of Afghanistan now. But the problems of the people of Afghanistan remain, and so I'd like to hear your thoughts about, when we talk about crisis, we think, oh, today, immediate. But some crises go on for our lifetime, and how do we address that, in your view?
Great, thank you very much. Yes, we'll take one more and then we'll yes.
Thank you. My name's Danny Murphy. I'm from Chemonics International. Thank you all for a wonderful panel. My question is directed at Ms. Kraus. Ms. Kraus, you mentioned that the capacity to address reproductive health in crises has increased partly because of the involvement of development implementers. And I was wondering if you could just speak briefly on how development implementers can coordinate in the field with emergency implementers. Again, just briefly. Thank you.
Okay, yes, I think we had someone else had their hand up. Yes, and up front here.
Hi, my name is Amanda. I work for the Department of State, and I cover reproductive health in crisis for the Bureau of Population, Refugees, and Migration. My question is about, maybe for Sandra, about the Family Planning 2020 midterm report that came out. So they're way behind their goal, and one of the things that we're talking about, we support UNFPA in humanitarian settings, is are we focusing too much on supply chain instead of demand creation? So we have a little bit of an issue with, as far as research for the indicator unmet need, because the unmet need indicator is a little bit skewed because they use an example of some of the countries in Africa where women actually don't desire contraceptives. So that unmet indicator is skewed because you're talking about demand for contraceptives, and some of that, the cultural preference for larger family size or effective, fear of side effects. So I'm just curious what you think about that indicator and Family Planning 2020, their progress and the fact that they're so far behind their goal.
Great, thank you. And before we get to second round, I'd like to add one question, and the question for I think for me is part of a reaction to Sandra's response to that elevator pitch. I think, Sandra, you started with family planning, and I wonder if the person in that elevator was someone who was part of the transition team for the new administration, whether that would affect how we should be talking about these issues. What's our point of entry or different ways that we should be thinking about how we present these issues so we can begin to think about ways to position the United States to continue to support in this very important work. So we have five things for us to think about. How do we position this vis-a-vis the new administration? The 80-20 rule, does that resonate with you? How do we deal with donor and organizational fatigue when we are dealing with crises that may go on for a lifetime? how can we increase coordination and collaboration between development and emergency implementers? And how do we deal with indicators that focus on issues that arise within supply chain versus demand creation context? And how do we do that cognizant of cultural and respectful of cultural dimensions? So we will start with you, and you can address any of the above.
Yes, some are not easy. The 80-20 rule, you were not referring to terrorism per se, correct? But just the idea of success, because some of the issues that have come up more and more, as you may be aware, are actually is that, particularly as we're moving, which we didn't talk about, but the other big switch in the humanitarian world is moving towards cash-based interventions. And so in Jordan and Lebanon, UNHCR, WFP in particular, are giving a lot of money, and I think it's a very interesting way to move forward, and I'm convinced it's very good for some things, but we don't know about health yet because of the supply side and demand side. So I was thinking when you were talking about that, potentially there's an issue there about some of that money towards untoward costs. But my response would have been, it's easy when you have food or blankets that you're given just to sell the blankets for money. I mean, most of the issues there. So 80-20 rule, the answer is I don't know, because I think it's very hard in these situations to actually have a good educated guess of what will work and what will not. So it's hard to know what would be the 80 and what would be the 20, and would that stifle innovation? Because I think the key thing here is innovation. What I mean is, if I understand the question, you're saying that if there's an 80% chance of success, should we move ahead? Is that correct?
If you feel somewhat, I feel like because we're all scientists, a lot of us feel that we have to communicate more uncertainty than certainty.
Right.
But if you apply some common sense and say, if we take action now, taking action now may be better if we're kind of sure it's going to work, rather than doing nothing until we're absolutely sure it's going to work.
Right. For sure, and Sandy was talking about before the idea of preparedness, which is another issue, of course. With preparedness and prevention is always better, but there's never any money for that. So I guess the answer is yes, but in certain areas, sometimes the estimation or the precision of such an estimate may not be there. Very briefly on my side, because there are a couple interesting areas, and I'll just talk about two. One is the donor fatigue. It's a major issue. I mean, it's not just Afghanistan is a wonderful example. Sadly, so is Somalia. So are refugees. There's a lot of numbers bandied about, and they're probably none of them are correct. But some talk about 17 years. A refugee is a refugee. It really depends how you. So I would stay away from that number because it's probably not scientifically sound. But the point is, refugees stay for a long. Once you are displaced, whether you're an internally displaced or a refugee, you actually stay displaced for a long period of time. So it is a major issue. A lot of this, though, comes to a bit what you were talking about, Roger, in terms of transition team, is how you talk about the successes or the failures. But Afghanistan will be problematic, clearly, because it's political as well. And when you look at what has happened, there's a question: well, why is Afghanistan still in this state now? I think it will be a problem. And what we've seen, and then I'll stop on that because there isn't a good answer, but what we've seen is that the needs currently have grown significantly from what they were a decade ago. The money that is provided to humanitarian response has increased, but not proportional to the needs. And it has disproportionately gone to Syria situation, which that's not a bad thing, of course. But what we saw at UNHCR is a lot of the protracted situations now, because the money, it is a bit of a zero-sum game, although it's increased, but disproportionately. Therefore, those long-term refugee camps are actually getting less and less money. And I would gather the same thing may happen in Afghanistan. Somalia, we've been talking about forever, so I'm not particularly optimistic there. And maybe one aspect, although it was directed towards Sandy, but there is a big push now, what's now called, has been called for a long time different things, but the humanitarian development nexus. So trying to look at development and humanitarian, it's nothing new, but maybe the time is right. And one of the reasons the time may be right is actually because of the Syria situation. So the Syria situation will have major effects on humanitarian response for a long, long, long time. So even when I was at HCR, we started to push with Lebanon, when you suddenly realized that whatever number you wish to use, 1 in 3, 1 in 4, 1 in 5, people in Lebanon is a refugee now. Persons are a refugee. So it affects the development, and you can't look at Lebanon and just say we're going to continue with the development plan when you have all of these people here. And the World Bank has become very much involved. There's a new flagship report that came out 2 months ago that I would highly recommend you look at. And it's been really interesting because we're trying to respond differently to a humanitarian situation. If there is a camp, and we don't wish there to be a camp, we're suggesting now you don't put it in a remote area, of course. We never wanted to, but the government often insists. But look at the development plan. Look at where the population growth may occur, so that you're creating infrastructure that will be used when the refugees go, even if it may be a couple generations. Look at where the markets are. Use existing schools, existing health systems, and capacitate them as opposed to just having parallel systems in the camp. Easier said than done. And then I'll just end by saying what the World Bank is looking at with HCR and others was to look at the livelihoods in this area. Look at what are and I'm talking now the host community, what is lacking? What are some of the skills that are lacking? Can the refugees actually fill this? Many of the Syrians are quite well educated, doctors, lawyers, nurses, etc. And then can we negotiate with the governments so that we can have a win-win situation? Because classically, and it all comes down to politics, in Jordan when you have 50% or 60% unemployment amongst the youth, they're going to say we don't want to give refugees a job. But if we can work with them, and particularly with the bank, to ensure that more taxes will be collected, and that when you look at the micro areas of where the refugees are, the economy is increasing. When you move towards cash-based interventions, refugees are buying goods locally. There's a multiplier effect of it's up to even 2.2%. So you give $1 to a refugee in the locals, that dollar will go longer. So there are different ways of thinking about this that I think will have a longer-term effect and will also bring in the private sector much more than it has in the past.
Thank you. Sandra?
Yes, I guess I will pick up on the development capacity, what they have to offer, and the nexus with humanitarian organizations. I think it helps that more humanitarian agencies are doing development, and more development organizations are actually doing humanitarian work, and that came out in our institutional capacity study in the global evaluation. I thought it was quite interesting. But, development organizations are on the ground long term. They have the relationships with the government. They have the relationships with the local NGOs. They know the culture, and they're just much better situated to respond, I think, in an emergency, to be supported to respond in an emergency than a humanitarian organization if they're capacitated to do so. But I'm also a huge fan of the work that's going on in disaster risk management. That is, when a country like Pakistan's in a stable phase, they integrate disaster risk management for health and other issue areas in their national plan, and all the way down to the community level, where communities themselves know what risks they face in flood after flood. What are the specific risks to women and girls in those crises? What can we do to mitigate the effects of those crises? And communities can learn that they need a communication system for emergency referral if a woman's having a complication of pregnancy and childbirth. They know that when the society is disrupted, women and girls are going to be at risk of sexual violence. Their families are broken up, their communities are broken up. It happened in New Orleans, it happens everywhere. What can we do to put measures in place so that doesn't happen? And what can we do to make sure that women who suffer from those events have care so they don't have to further suffer unwanted pregnancies, unsafe abortions, and death? So I think that I'm really a huge fan of that, and that's the place and the time, I think, is when fragile countries are in a stable phase to try as much as possible to put these interventions in place. And I'll just give an example of work we've been doing or recently started in Pakistan, because I just want to give a shout out to a local NGO there, the Family Planning Association of Pakistan, who's been there for 60 years, and they're all over the country and they're doing fabulous work. Brought them together in a workshop with the UN agencies and the other local partners and did a training on gender and sexual and reproductive health risk in emergencies. and work to try to get them to roll that training out, a trainer of trainers at district and community levels, and at the same time, those UN agencies to continue working on national support for those community level interventions. I think that's, we have to try to mitigate the impact of these disasters on so many levels, and we know in the United States when there's a huge earthquake, we don't have the same problem because we've put measures in place to mitigate the consequences. So I think that's pretty important. And then on the FP 2020, I can't speak to them. All I can say is that we've advocated very hard to have fragile states and humanitarian contexts be part of FP 2020. To date, we haven't been. But there has been an anonymous donor that supported several of the large service delivery organizations to provide family planning in crisis-effective settings, and they've been highly successful. And it's not a question of convincing anyone to use services. It's a point about making multiple options for family planning available, which increases uptake. And all three of those, and a lot of that work is published or going to be published because of the tremendous amount of uptake. But then that's 3 international NGOs and 1 anonymous donor. So we know that they can be successful and work, and there's a demand, and there's not a lot of issue around having to convince anyone or advise anyone. It's more having the logistics, having the supplies, meeting the demand that's already there.
Transition.
Any thoughts on the transition?
Transition government. Yeah, the transition.
Yeah, you didn't get that one.
'Cause you're,
The transition? No. Well, I can't quite remember the question.
We have a new administration.
That. How would I handle that? That transition. Some things you just do try to block. No, I obviously I'd approach it a little bit differently. I mean, I'm a practitioner, so I really do like to go straight to the. But I do think that you'd position family planning in terms of its economic benefits, of which they're tremendous. So I think that would be the approach on that for family planning. It would just be the overall economic benefit. Yeah.
Okay, thank you.
I think.
All right.
When I think in terms of this 80-20 rule, I'm a really quantitative person, so then to me I think, ooh, that sounds really good. But in this context, when we think about investing, when we look at the entire portfolio for women and children's health, we could easily apply an 80-20 rule. And that was one of the things I was talking about, saying balance your portfolios so that you can convince others that this is a worthwhile risk. Now when you get down to, so then we say, okay, well, 20% can be in these perhaps more risky investments. But then when you get into that 20%, we do everything that we don't have an 80-20 rule, but were we to have one, we do everything we can to mitigate risk along the process. So the great part about our team is they are not a team of philanthropists, they are a team of technical experts. And so because they have a lot of experience, many of them came came out of the field in working in health already. So there's a variety of different types of people on the team. They're very good at having those conversations and thinking about what can we do to mitigate our risk and to improve our chances of success, and also to have what we need to encourage scale later, long after we're gone. So I love the idea of an 80-20. I'm not sure when you really start talking about country by country how practical it is. And then in the Afghanistan question, that was kind of heartbreaking question. About donor fatigue, I would say we have a very quantitative way to prioritize the countries that we want to work in. So there's no fatigue involved. These are what the numbers tell us. These are the places, and we actually in those basically we look at every country in the world, and we have things that we feel are priority aspects that we want to look at. So maternal mortality, number of midwives in the country, if this is maternal health, political will, and we have rankings for political will. So fatigue doesn't really enter into that equation because it's strictly quantitative. And then we say, okay, here are the places that we feel are the most important to work in for now, and then we look at what we can do, and we look for partners. I will say most of the time it's not partners approaching us. We seek the partners that we want for the places that we want to work in.
Great, thank you. Any other questions? Yes, we'll take
My name is Deirdre Lepin. I'm attached to the University of Pennsylvania. I was also a scholar here at the Wilson Center at one stage. I've worked in a number of these areas. One is CSR. I've also worked in maternal health. I have a master's in public health, international from Johns Hopkins, and I also now work really on Nigeria. So you've raised a number of issues that I think are interesting, but one that has impressed me the most recently, because I've been doing a number of maternal health surveys and projects in northern Nigeria, and some of those areas were affected by Boko Haram, is the issue of demand. The fact that 1 in 10 women die of reproductive health, as best we can estimate, in northern Nigeria in general, is really an extraordinary figure. And it seems that to a very large extent it's not because services are not available, and much of your data collection and so on has to do with the supply side. But the demand side was also mentioned in relation to family health, but it could also be related to reproductive health in general. How much information are we collecting, or what do we know about demand? What do women know about reproductive health? And what do communities know, and how much do they support these women in seeking reproductive health? And what do you think can be done to perhaps increase this focus on demand?
Okay. So in addition to that question, I think my final question for you will be, if you reflect on what we've been discussing, the research, the results, your corporate engagement, what do you know now, today, that you wish you knew 5 years ago that may have changed how you've been working on this set of issues? What do you know now, today, that you wish you knew 5 years ago that would have made a difference in how you've done your work in the past few years? So perhaps, Joy, we could start with you and then come up this way.
No, I'm still thinking.
You're still thinking? All right.
Go first.
All right. So, Sandra, can we start with you? If you want to address the demand question and sort of reflect a little on where you are now and what you wish you knew before.
I think we probably do need more studies. Oh, sorry. I think we probably do need more studies on what populations understand and know about just basic anatomy and physiology and reproductive health, because my personal experience is just being in a lot of these settings that are war-torn decade after decade, like Myanmar. Girls don't have a chance to be in schools, boys either. They don't learn how the body functions. They don't know what to do to prevent, pregnancies or all kinds of problems, and what to do if they have a complication of pregnancy or childbirth. So I know there are efforts to do this sort of information, education, and communication, and also to integrate. UNICEF's tried to integrate, and UNFPA, into early childhood education programs, elementary school education programs for refugees. But I think it's a good point. I mean, if people haven't had a chance to go to school, how would they know what would be useful and helpful in many ways? So I think that's a really good point, to be able to look at populations like that. What didn't I know 5 years ago? Well, I think a big learning curve for me has been this whole humanitarian development nexus, disaster risk reduction, putting effort into better identification and support for local, national capacity, and in terms of sustainable approaches and also mitigating the consequences of crises.
Thank you.
I think with the demand, we can learn a little bit from, it's slightly different, but from HIV and how it was necessary to, through IEC, information, education, communication, behavior change, to educate sounds too paternalistic, but to be able to inform people about HIV and then the changes that need to occur. Something like that could occur, I think, with family planning if there was a concerted effort. But again, I think we have to look longer term. So, I mean, it's easier, and I actually haven't studied this to know. We would have the information for longer term, but in protracted situations, I would guess in the refugee camps that family planning would have a higher uptake. But certainly in the acute emergency, so also what I learned with HIV doing is that you have to choose when to start implementing and providing knowledge. In acute emergency, it's classic Maslow's hierarchy. They're going to care most about their food, shelter, and so so we need. That's why the MIS was developed, to try to prioritize. But I think I believe there could be a way that we could increase demand for family planning over time. Probably not in the acute emergency, but post. In terms of what I didn't know, many things. I'm just trying to think where it's really how Syria, I think, has, let's say, changed the game. So I think one area that I'm really interested in now that hadn't been really thought about in the past were different ways of innovative health financing for refugees. So we've moved towards even refugee insurance in Iran. The Afghan refugees at one point, now it's changed, but we had 350,000 or so. Things that we would never have considered health insurance. Now I'm working a small project with the bank, looking at social impact bonds, looking at maybe catastrophe bonds and seeing could we move into some sort of humanitarian bonds. So there's a lot of really interesting ways to move forward that hasn't yet been sufficiently identified.
Excellent, thank you. Joy?
Okay, three musts. And maybe we knew these in theory, but we've really practiced them and have seen results. And I think in the last 5 years, country or community leadership. And it doesn't have to be both. It can, sometimes grassroots works just as well as top down, country or community leadership. The right advocacy, the second is the right advocacy can move individuals, and it can move the entire field forward. If you have the right advocacy, it's so powerful. And the last is being from CSR, so we said we don't drive business. Business that's J&J has a business, and that allows us to do CSR. One of the things I've really learned in the past year is our businesses, while we don't drive business, they can bring real value to these conversations in terms of new product distribution, new creative ways of thinking or analyzing the work that we're doing. And so we have started to bring them in more as in their expertise, not driving business, not driving product, but really bringing their business acumen to the table. That has been a big kind of aha for us as well.
Excellent, thank you. Well, Maximo was on with us until about 11, and then there was a power outage. So he sent us a message saying, so we lost him at some point, but we will loop back to him. But I was really pleased that he was able to join us for at least half of the discussion today. So I think we've covered quite a lot in today's discussion. It's a complicated and complex set of issues for us to think about as we think about ways to bridge the gap. And I think we started our conversation today by looking at the context. What do we know? What is the data? What is the evidence? What's the research? What's the information? How do you deal with challenges around methodology? And really think about what that means for us. we also had a discussion in that context about the urgency of needing to act in these situations. How can we move forward? We talked about the protracted nature of the issues at hand. You know, one of you described these as lifetime crises, and how does research and evidence play out in that kind of situation? And in terms of setting the context, we talked about the variety of actors who are coming to the table at the same time, and how can we think about coordination and collaboration in that context. In part of setting the context, we also recognize the development and refinement of guidelines over time, and our use of those guidelines, and thinking of how we get to making those guidelines relevant for specific context. So we were very careful in talking about the contextualization of action, using those guidelines in a way that is helpful and productive for us. So that, I think, was part of our setting the context, our discussion today. From my perspective, we talked quite a bit about partnerships. We learned about the capacity of NGOs and institutions on the ground. We talked a little bit about government efforts. We talked about community engagement, local institutions. It was quite interesting to me that on the panel, we talked about international NGOs and actors versus local actors. And I think, Paul, you were the one who said at some point they will be required to give up some of that power. So the questions of power dynamics around action and information on the ground also came up. And then the role of the private sector. How do we as a community engage with the private sector? But how do we learn from the example of our colleagues who are champions for us within the private sector, and they themselves are having to deal with this culture of no? How do you build the business case within the private sector itself? How do you talk about scale and sustainability? How do you then engage, and what do we learn to that? Is it the leveraging of an SDG commitment? Is it a question about markets? How do you build that business case? So there was a discussion that I think we had overall about partnerships and collaboration, which I think was very fruitful and insightful for me. I learned quite a few things. And then we moved to talking about ways to close the gap. This is really such a critical issue that we need to find ways to move on right now. There was a discussion among us about mapping and vetting capacity. How are we able to do that quickly? How can we have fast assessment methodologies? What's the role of technology in that context? Is it that we try to think about leveraging the web portals? How can we better use who's doing what where? How is that a source of information for us? And how do we build on reliable information that we can use to move to action, recognizing that at times the confidence level for that information is sometimes in doubt. We will not have perfect information, but there's a sense that we need to move forward and engage. And how do we deal with getting at a very granular level that Massimo talked about? You know, on the ground, what's happening, how do we get to that specificity at a very local level? We heard a very good push to call for increased timelines for measuring results. You know, part of what we also talked about was how do you report on these issues? How do you report on results? And how do you engage our partners on the ground who themselves may not perceive of themselves as being vulnerable? How do you move above and beyond this narrative of vulnerability to empowerment? Is it that you talked about fulfilled communities achieve success? An example that Joy talked about. And then finally, I think one new idea that came out was for us to be thinking about innovative health financing in this context. What are new and innovative financing models that we should be thinking about to help us deal with such a dynamic situation where we're able to measure risk and fast-moving action? So, wow. You guys covered a lot.
Wow, you're able to summarize it really well. I'm very impressed.
So please join me in thanking the panel and Massimo. Very, very rich discussion. I also want to thank my colleagues here at the Wilson Center. I'd like the staff and the team to just raise your hands so that people know who you are.
Thank you for your support.
This cannot happen without a team. As you know, it was webcast live. It's recorded. This will be video archived. You can access the presentations, and we will write a summary of the discussion today, which will be available to you on our web platform, newsecuritybeat.org. So please look out for the summary of the discussion. The resources are available for you, and we also have lunch for you now. So we have lunch for you just outside. Please feel free to stay a little longer, have some lunch, and continue to network and engage with your colleagues and the panelists. Thank you so much.
So that's really cool. With a Vietnamese mother, you definitely know who the Hmong are, yes, and who the Laotians
great.
are.
I had a great,
yes.
I'm Jim Toby, I'm a surgeon. Notice part of your essential surgery.
Yes, essential surgery.
I'm part of the G4 line. You know what that is?
Yes, I do.